This is a ridiculously heavy dumbbell. But that's not what we're talking about today. Welcome to Endocrine. Oh, jeez. Before we launch too far into Endocrine Week, take a few minutes just to kind of quiz yourself over the endocrine system. The pituitary, the thyroid, the adrenals. What do they do? What's their normal physiology? Refresh your memory there so that these disorders that we talk about then seem a little bit less frightening. Diabetes. Diabetes is a disorder of carbohydrate metabolism. What's the most basic unit of carbohydrates in our body? Glucose. Therefore, diabetes is characterized by high blood glucose levels, also known as hyperglycemia. A couple different types of diabetes. Type 1, type 2, and gestational diabetes. I'm going to tell you right now, I was never an OB nurse. I can't tell you much about gestational diabetes. Something to do with the mom and the baby and placental hormones or pregnancy stress. I don't know. I'm not an OB nurse. Type 1 and type 2 diabetes are categorized by how the hyperglycemia is produced. In type 1 diabetes, for 90% of cases, it's an autoimmune process. And it's an autoimmune process against the beta cells in the islets of Langerhans within the pancreas. Now, how many of you guys remember that your pancreas is both an endocrine and an exocrine organ? Pretty cool. Most of the pancreas actually is an exocrine organ, but there are these islets of Langerhans in which things like insulin are produced, glucagon are produced. And in type 1 diabetes, the classic autoimmune example, which if you want to get a little bit picky, call it type 1A diabetes, an autoimmune process destroys the beta cells in the islets of Langerhans. Insulin is no longer produced, and therefore glucose cannot be taken from the bloodstream into the cell through the normal cell signaling process that insulin starts. A lot of people think insulin and glucose kind of bind together and just kind of ram glucose into the cell through the cell membrane. That's actually not it. Insulin acts as a ligand that starts a cell signaling cascade within the cell, the end product of which is glucose entry into the cell. Insulin is the starter of that cell signaling cascade. Glucose entry is the last process in that cascade. Now for type 1B diabetes mellitus, I gotta tell you, technically it's idiopathic, meaning we don't actually know why people lost their beta cells. The cynic in me wonders if this is an autoimmune process and we just haven't identified any antibodies yet. Now type 2 diabetes, opposite gig here. In type 2 diabetes, there's ample insulin. The pancreas is fine, but the cells of the body have become resistant to insulin's cell signaling effects. This all goes back to cell signaling. This is termed insulin resistance. 90% of diabetics are type 2 insulin resistant diabetics. So, who cares, man? So my blood sugar goes up. Whoop-de-doo! For the most part, you can't really feel your blood sugar elevate until things get markedly high. But here's the problem. Having elevated blood glucose levels, hyperglycemia, leads to endothelial damage. Think about that for a minute. Where in your body is there not vasculature? If hyperglycemia causes endothelial injury, speeds up the processes of things like atherosclerosis, then diabetes becomes a major, major health concern. Because we have then body-wide complications. So the title of this slide is Advanced Basic Pathology. Maybe I can even take the word basic out of it because there isn't really that much basic to it. Hyperglycemia-induced endothelial cell injury causes accelerated atherosclerosis. That should scare all of us. For those of you who are interested, I have a couple papers listed here that try to go a couple steps deeper into the exact biochemical pathways by which hyperglycemia injures endothelium and ultimately accelerates atherosclerosis. The only thing I will bring to note on this particular slide in the explanation is that end product that you'll see down at the bottom talking about increased amounts of free radical generation. Now, free radicals and the damage that they form is not a new concept, but when this is going on all the time in a hyperglycemic state, over the course of months to years, we have the potential for body-wide problems. Now, type 1 diabetes used to be called juvenile onset diabetes because that's when most cases occurred. Like many autoimmune diseases, the onset tends to occur at relatively younger ages. To say that another way, it's relatively rare for a 65-year-old to suddenly develop type 1 diabetes. Contrast that with type 2 diabetes, which is a pathology known to usually not be diagnosed till later in life. The caveat here is that due to poorer and poorer versions of the standard American diet, type 2 diabetes is actually being diagnosed in younger and younger individuals. The interesting thing about type 2 diabetes is that even though the pancreas can make enough insulin, and in the early stages of the disease can actually compensate by just producing more insulin, it's a compensatory mechanism. We know about compensatory mechanisms, right? That's a principle of patho. Our body's full of compensatory mechanisms. Can we use them forever? Nah. So in the early stages of type 2 diabetes, those patients are actually hyperinsulinemic. If you measure circulating insulin levels, they're cranking it out because their body and their pancreas specifically is trying to compensate for the insulin resistance in the tissues. And that compensatory mechanism is crank up the insulin. Compensatory mechanisms do not last forever. Eventually, the ability of the beta cells to crank out insulin is lost, and actually, type 2 diabetics, over time, will have beta cell exhaustion, beta cell loss, and eventually basically become type 1 diabetics themselves. So take a few minutes and look at this graph. This graph represents insulin production on the y-axis and time on the x-axis, the time to the development of clinically appreciable type 1 diabetes mellitus. So if you look at the slide, at the top of the graph, you have those initial insults that take a genetically susceptible individual and put them through the autoimmune ringer, so to speak, whereby pancreatic beta cells start to be lost. But is it an instant thing? No. It's over time. More and more beta cells are lost to autoimmunity, and it isn't until more than 50% of them are lost that clinically apparent hyperglycemic diabetes type 1 is measurable. This chart is meant to demonstrate the importance obesity has as a risk factor and perpetuator of the development of type 2 diabetes. It also helps to validate why patients who are able to lose body weight can essentially reverse their type 2 diabetes. This is provided enough pancreatic beta cells are still active. So let's just go around this diagram and explore what increased adipocytes do to the body. Now, clinically, you may still hear terms such as borderline diabetic or pre-diabetes. And these are important terms to think about or consider, as these patients that have these labels are not yet confirmed to be diabetic, but they're almost there. For example, a borderline diabetic may currently have a normal blood glucose level. However, they have been shown to have excessively high or hyperglycemic episodes in the past. So there's at least some proof that those normal glucose control mechanisms are no longer as strong as they used to be. Prediabetes is a pretty broad term because it can include basically anyone who has the right risk factors for becoming diabetic, type 2 specifically. And then in addition to clinical terms such as borderline diabetic, pre-diabetic, I also want to introduce you to the term metabolic syndrome. Hopefully you hear this more commonly than you hear borderline diabetic anymore. However, those patients that are pre-diabetic and have shown some degree of impaired glucose tolerance, there's a heck of a lot of overlap with those people and what the qualifications are for having metabolic syndrome. Persons with metabolic syndrome have insulin resistance, hypertension, dyslipidemia, hyperinsulinism, perhaps, obesity. Persons with metabolic syndrome are similar to pre-diabetics in that they're just kind of type 2 diabetics waiting to happen. The important thing for us to remember as clinicians is this is a great time to intervene and reverse what's going on before beta cell exhaustion occurs down the road and type 2 diabetic patients essentially turn into type 1 diabetic patients. Well, when it comes to risk factors for diabetes, they're quite a bit different. If you think about your type 1 diabetics, the risk factors are essentially going to be whatever triggers that autoimmune response. In a type 2 diabetic, however, opposite case entirely, where lifestyle is the risk factor. And as I've mentioned, type 2 diabetes is 90+% of your diabetes mellitus cases. So knowing the basic pathology of these two different forms of diabetes mellitus may actually help you figure out their clinical presentation a little bit. Look at these two columns and then look at their commonalities first. The three things that both types of diabetics have in common are the polys: polydipsia, polyuria, and polyphagia. All three polys are a consequence of hyperglycemia and not delivering glucose into cells. Let's start with polyuria. High amounts of glucose in the blood increase the osmotic pressure of the blood, drawing fluid back into the vasculature. Remember your three variables for fluid maintenance between the vasculature and the extravascular space: hydrostatic pressure, osmotic pressure, and oncotic pressure. High levels of glucose in the vasculature have an osmotic effect, drawing fluid from the extravascular space to the intravascular space. This is why glucose is used for dialysis patients to draw excess water out of their bloodstream. In a patient with diabetes, that excess glucose in the bloodstream draws fluid into the vasculature, and once it's in the vasculature, what's it going to do? It's going to hit the kidneys, and the kidneys are going to do what the kidneys need to do: pee it out. So the primary symptom of a patient with hyperglycemia, whether they're type 1 or type 2 diabetic, is polyuria. Now here's a fun little aside. I just think this is the funniest thing in the whole world. So, since polyuria is the main clinical symptom, you got to go back 150 years ago, 200, I don't even know how long ago, and think about people who had polyuria and are presenting to the local clinician, the local doctor, and it looked as if, it was the urine that was the problem. I mean, it makes sense, right? Who would have thought about excessive blood sugar then? So, since the urine was the problem, it needed to undergo some diagnostic workup. And in doing so, one of the diagnostic workups was to taste the urine. And guess what? The urine tasted sweet. Sugar was spilling into the urine, giving it a sweet flavor to it. The name diabetes mellitus literally means one who pees sweetly. So while hyperglycemia causes polyuria, and that polyuria then triggers thirst mechanisms that lead to polydipsia, polyphagia is probably a byproduct of not delivering glucose into cells, triggering then a hunger response. So in terms of the three polys, the two types of diabetes mellitus do overlap. So I have one discriminating feature for both of them that I'm listing here as clinical presentation. Type 1 diabetes mellitus patients are at risk for a state called diabetic ketoacidosis. We're going to explore that in a second. Type 2 diabetics are at risk for a syndrome called hyperosmolar hyperglycemic state, HHS. Also called, this will really get you, hyperosmolar hyperglycemic non-ketotic state. We'll talk about that in a minute too, but in a nutshell, it's everything diabetic ketoacidosis is without the acidosis.